Okay, very good afternoon, everyone. It's my pleasure to be here today, and I can see that there are almost 400 participants. Thank you for joining me here today in conjunction the World Kidney Day this week, and hope to take about 45 minutes of your time to talk about chronic kidney disease, fact and myths. I always like to show you this first slide, right? This first slide, over the last 2 years, we are all concerned with the numbers of COVID patients, but these slides instead tell you the number of kidney patients in the world. As you can see here, right, in 1990s, there's roughly about almost 500,000 patients on dialysis, meaning chronic kidney disease stage 5 in the world. And these figures actually have doubled to 1 million in the year 2000. And in year 2010, again, it doubled to 2 million patients on regular dialysis. And this slide itself shows you that the number, the severity of and the burden of kidney disease in the world. All right, and back home, these are the slides courtesy of our National Renal Registry. We have a very good registry in Malaysia where we actually note down all the patients actually requiring dialysis in Malaysia. And you can see here, we have a total of 7,200 new patients on dialysis in the year 2018, right? In 2018. And in the year 2018, we have a total of almost 40,000 patients on dialysis in Malaysia. And you look at the figure 10 years ago, which is only 17,000 in the year of 2008, these figures has also doubled. So this is correspond to the world figure, and in fact, Malaysia even more than double. All right, so before I proceed further with the presentation, I would like to just ask you all to grab a piece of paper and a rough piece of paper and a pen, and I would like to ask you a few questions, right? Simple questions, but I hope at the end of the presentation, you'll be able to answer them correctly. Okay, so question number one. This is one of the questions that a lot of my patients ask me. That is, patient one started on dialysis treatment. Will all patients need continual lifelong dialysis, right? Because similarly, a lot of patients ask, if I take blood pressure medicine, do I need to take blood pressure medicine lifelong? If I take diabetic medicine, do I need to take diabetic medicine lifelong? So in this question, if a patient need to be started on dialysis treatment, does all patients need to be continued on lifelong dialysis? A, yes. B, no. So just try to note your answers. We'll discuss about it at the end of the presentation. Right, question number two. Right, diabetes is the most common cause of renal failure in Malaysia, right? I'll give you the answer itself. That's the most common cause of renal failure in Malaysia. What do you think is the percentage of renal failure due to diabetes? Do you think it's just 5%? Is it 25%? Is it 45%? Is it 65%? Or is it 85%? Right? So if you think its contribution is low, maybe 5 or 25%. If you think the contribution is high, then maybe 65 to 85%. Give a guess. And number three, right? I would like to also ask, what is the second most common cause of renal failure in Malaysia? Obviously, it's not A, because as I already mentioned to you, diabetes is the most common cause. So the question here is second most common cause. Is it hypertension? Is it glomerulonephritis? Is it polycystic kidney disease? Or is it unknown? Unknown, perhaps drugs, traditional medicine, and so on. And finally, number four questions. How long do you think a kidney failure patient on dialysis can survive? So I'm sure you have in contact with dialysis patient. Not sure whether you have seen any patient more than 10 years, 10 to 20 years, 20 to 30 years, 30 to 40 years, or perhaps you think that they can survive more than 40 years. So these are the four questions. I hope you'll be able to answer correctly at the end of my presentation. Okay. So what are facts and myths that I'd like to discuss today? Right. These are the three important and common questions that I face during my usual clinic session. In fact, I face all these three questions during my clinic session this morning itself. Right. The first question that I always get is, can I regain my lost kidney function? Most of my patients who comes to me, walks into my clinic, the first thing they want and the first thing they hope is to actually regain their lost kidney function. And the second question, very common, is that did my medication cause my kidney problem? Most of the patient actually suffers from certain medical condition, diabetes, hypertension, and it's very common for them to ask, is it my medication that caused my problem? And finally, there are all some very depressed patients who I will ask, I have kidney problem. Doctors have told me that my kidney is failing. Will I die? And of course, number 4, there are many, many more questions which I don't think time is sufficient for me to cover all. I will try to cover these 3 main questions that I get during my clinic practice. Okay, first question, can I regain my lost kidney function? So with this, I'd like to bring you to a case, a 72-year-old retired teacher, who came to see me a few years ago. She actually felt lethargic. He doesn't feel normal. He feel that he was unwell. He had been hypertensive for 20 years, but well controlled. He's a teacher, so he actually takes good care of himself. So because of his lethargy, he actually went to a private lab. He did a blood test, and to his surprise, his creatinine was 370 with a eGFR of only 15. That alarmed him, and therefore he came to my clinic because his wife is actually my patient, so he came to my clinic. And seeing his results, I did a urine examination, which was normal, and I did a simple bedside ultrasound kidney, and that was also normal. And subsequently, I made some questions. I asked him some extra history, and he told me that he actually went to Taiwan recently. That was before the COVID era. And while he was in Taiwan, because he was in a tour group, and this tour people had to move from one place to another place, and because he had some knee problem, he actually walked very slow and delayed the group, and therefore he was feeling unhappy and he felt ashamed. And finally, the tour guide actually offered him some medications, and he took the medicine and he felt much better. He can actually walk faster, relieve his pain, and because of that, over the last 2 weeks while he was in Taiwan, he took the medicine. So based on that history, I told him, well, don't worry. I gave him some vitamins, and he repeated his renal function in 2 weeks. And well, his creatinine came down back to 120 with an eGFR of 52. So this is a very obvious example of a case of acute kidney injury. And likely due to medicine, and this medicine likely to be painkillers. I do not know what painkillers, because he also did not know the name of the medication, but obviously this is acute kidney injury. So acute kidney injury is very common in our patient load. This is another example of acute kidney injury. A patient who actually been followed up with me over the years for hypertension. You can see that his creatinine in 2014 was stable, 2015 it was stable, 2016 it was stable, and then in 2019 he was down with a lobar pneumonia. He had a pneumonia, and you can see the creatinine shoot up to 219. With the treatment of lobar pneumonia, with antibiotics, he recovered, and the renal function subsequently also recovered. So another example of acute kidney injury. Another more extreme example of acute kidney injury, you can see here in this patient who actually presented, again, this is a 56-year-old teacher, who actually presented to me with a creatinine of 1,000, right? But luckily for him, he was not really symptomatic. He had diarrhea for 1 week, but he did not seek treatment. Unfortunately, he was also a diabetic and hypertensive, but he diligently had been taking his diabetic medicine and hypertensive medicine despite BP was low at presentation. He was taking his perindopril, he was taking his metformin despite having his diarrhea and not able to tolerate orally at that point in time. When he came in, as mentioned here, creatinine was 10,000. We repeated the tests daily and it was still 1,000. But based on the scanning and the urine examination, there was no protein and the normal kidney, and he was not symptomatic. We just hydrate him with fluids, treated his diarrhea with anti-diarrhea medication, stopped his diarrhea, and you can see over at the period of about 1 week, the renal function actually recovered without dialysis. And he subsequently in 2008, subsequent to 2018, 2019, and of course, latest, he just came about, I think about a month ago, his kidney function has remained relatively stable, and he of course recovered from his initial insult in 2018. Another more extreme example, this is another young man, 42-year-old, who presented to our casualty, collapsed. He was actually resuscitated, asystole. He was actually resuscitated with CPR for almost 20 minutes and subsequently diagnosed to have thyrotoxic storm, thyrotoxic cardiomyopathy, and he was actually resuscitated in casualty, and he was actually ventilated in ICU. And because of his because of his resuscitation, he developed acute tuber necrosis because of low BP, and subsequently you can see that his creatinine was normal at the beginning, rising until it was 918, and he had developed metabolic acidosis. Subsequent to that, I have to actually initiate him on dialysis. But the good thing about him is that once after initiation dialysis, as you can see here, after 2 weeks of dialysis, he actually recovered. The kidney function subsequently improved, and he was off dialysis roughly about 2 weeks after the initial insult. So, and subsequent, the last follow-up, his renal function was normal. Another example, in fact, is a very recent example. A 56-year-old gentleman, again diabetic, on follow-up in IJN, Institute Jantung Negara, who actually on cardiac medication, ramipril and metformin for his diabetes and ramipril for his hypertension, presented to me again with AGE with a creatinine of 888. He was lucky at that first presentation in the sense that he was not symptomatic. We hydrate him, and you can see here without dialysis, he actually improved, and his renal function actually returned to almost baseline. Of course, not normal, but baseline of 175. But subsequent to that, he was again unfortunate just prior to, I still remember him because just prior to Deepawali, 1 day prior to Deepawali, he actually attended a function, he took some food, and he subsequently had another episode of severe diarrhea. And at that point in time, he actually started back on metformin because he noted that sugar was increasing again, and he developed severe diarrhea and worsening of the renal function again. This time he actually was presented with acute pulmonary edema in our casualty. He actually presented at 11 p.m., need to be ventilated. Thanks to Dr. Gopeki, our NS, he was ventilated. And once we stabilized him, he was started on dialysis. Again, after about 1 week plus of dialysis, his renal function again recovered. So, can I regain my lost kidney function based on my few presentations that I shown earlier? If this is acute kidney injury, the answer is yes, right? A resounding yes. So if there is kidney injury because of drugs, herbs, dehydration, or infection, like acute gastroenteritis, UTI, and sometimes viral fever like dengue fever, you can actually recover the lost kidney function. But unfortunately, if you diagnose to have chronic kidney disease, it's a chronic condition. When we say chronic kidney disease is chronic, the answer is no. We can only retard the progression of the kidney failure. Right. So in retardation of kidney failure, the main thing is to delay progression. So we cannot improve, but we can delay. Of course, management of chronic kidney disease also entails management of CKD complications, timely preparation of renal replacement therapy, management of CV risk factors, but I will concentrate on delay progression because this is the main. So this is a chart I always show my patient, right? If we able to naturally progress, meaning that we age naturally, everybody will get old. I remember I don't have so much white hair, but now I have much more white hair now. So everybody will get old one day. As you can see here, if we naturally progress with a loss of kidney function of 1 mL per minute per year, and starting at 100 at age of 25, our kidney should last us until 115 years old, right? Because to reach 10% of kidney function where we require dialysis, and if you reduce at one rate of 1.15. But unfortunately, a lot of our young patients do not take care of their diet, they don't control their sugar, they don't control blood pressures, they take painkillers whenever necessary, whenever they think they have pain. So that kidney function can be lost at a much higher rate, and therefore now you do see kidney patients at a very young age requiring dialysis. So if a person at the age of 25 lose their kidney function at a rate of 5% a year or 5 mils per minute per year, they can actually end up in dialysis at a very young age. So if you can actually treat this group of patients and move it back to the natural progression, they will never need dialysis. So how do we actually delay chronic kidney progression? Well, delayed kidney progression is graded to many grades, grade A, B, C, and D. We can control the sugar to HbA1c of less than 7. We can use our RAS blockers, ACE inhibitors, angiotensin receptor blockers, and of course, new kid in the block, SGLT2. We also have grade B evidence of CKD progression, that is to control the blood pressure below 140/90, treat the acidosis, and finally, we also have grade C evidence where we can delay progression by dietary protein restriction, low salt intake. We also can help the patient by treating the hyperuricemia, treat the renal anemia, and the renal bone disease. So today, I will try to talk on dietary protein restriction. Why I concentrate on dietary protein restriction? Because this is something that you can empower patient. You can empower the patient to actually help themselves. And it's actually a very confusing and difficult area because a lot of patient thinks that by cutting down protein to a matchbox size, this is our teaching many years ago, our teaching was to actually cut down the protein to a matchbox size per day. That may have some truth, but unfortunately, if we were to cut down our protein intake to just one matchbox per day, we'll see our kidney patient to be like this, very cachectic, and perhaps the kidney function can be maintained, but they will be malnourished and may have suffered from other consequences of malnourishment. So what do we do? Right? We actually try to promote low protein diet, and we guide the patient towards this low protein diet. So how I try to give you a simple guide, because it's not easy. Most of the time we'll try to get the assistance of a dietitian, but this is a simple one. If you can follow me, let's put it this way. Low protein diet is roughly about 0.6 gram per kilo per day. So for example, if you have a 60 kilo patient, right? Make it simple. We have a 60 kilo patient, low protein diet, 0.6 gram per kilo. So roughly about intake of about 36 gram protein per day. So if you tell patient, please take 36 gram protein per day, they'll be confused. They'll probably scratch their head. They won't know what to do. So what do you do? Right? Okay, the 36 gram protein a day for a 60 kilo, average 60 kilo patient should be divided into two. We call it 50% high biological value protein and another 50% low biological value. So if you have 36 gram, then you are talking about 18 gram high biological protein and 18 gram low biological protein. How do we actually guide the patient? Well, we have taken 3 meals a day, right? So each meal should be about 6 gram high biological protein and 6 gram low biological protein. Usually I would try to give this to my patient. I think you can actually Google this from the Fresenius website and download it. All right. So the good thing about this chart is it gives you an idea about high biological protein over the right side, on your left side, and low biological protein on the right side. And you can see here, each portion here is actually about 7 gram, and each portion over here is roughly about 2 gram, right? 2 gram of protein. So it's also good that they actually divide it to non-vegetarian and vegetarian choice. So if your patient is non-vegetarian, you can choose the above. If they are vegetarian, then you choose the below. Of course, non-vegetarian also can choose the below as well. So what I usually tell patients, all right, for example, breakfast, you can take 1 portion here and 3 portions over here. For example, 4 scoops of milk powder, two slices of bread and two slices, of crackers for breakfast. As for lunch, you again can choose one portion over this side on the left side and three portions on the right side. And as for dinner as well, you can do the same. One portion on the right side and of course three portions on the left side. As for the details, you can download it from the internet, or if you can't find it, you can come to me, or perhaps you can contact your Fresenius rep. They can always give you this chart, and they have plenty of it available to guide your patients on how to actually do low protein diet. Right. So with low protein diet, right, we hope that we can actually, if the patient progress to kidney failure in 7 years, right, we hope to actually delay the progression to 9 years. And of course, if we start the treatment early, we detect the patient with chronic kidney disease early, we hope to actually delay it further to 11 years. And of course, if possible, aggressive treatment, we hope that can delay forever, and therefore the patient do not reach the requirement of dialysis. Right? Of course, despite, if you just do low protein diet without any supplement, our patient will still end up sick and malnourished. So what do we do? Of course, there is available supplements, ketosterol, which actually is a keto acids, which consist of 9 essential amino acids with keto acids that actually promote nutrition for patients. You can see here there are plenty of studies that shows that with the conjunction of very low protein diet with keto acids, right, you can actually delay patients' progression to renal failure up to 4.6 years. And mind to say that this group of patients started off with a very poor GFR. They started at about 15, 16 GFR, and they can be delayed for 4.6 years. That is considered very, very good. Right. So what are the mechanisms of keto acids? A lot of people, they think this is just a supplement. No, yes, it is a supplement, but it helps to actually remove urea. Okay, how does it do? Usually when we take proteins, amino acids, it's actually become nitrogen waste, which is removed by the urea removed by the kidney as urea. But with the presence of keto analogs, keto acids, the keto acid can promote these amino acids to become essential amino acid that can be used by our body. At the same time, because we're actually able to convert them into more essential amino acids, it will improve the nutritional status of our patient. So with the improved nutritional status, and because of that, we can actually cut down on the protein diet. There will be less nitrogen in the diet, and endogenous nitrogen diverted. That means there will be less nitrogen formation. Therefore, patient is less uremic, and this reduce the load on kidney, and subsequent to that, improve kidney function, slow down the chronic kidney progression, and of course, other metabolic benefits. Right. So I'd like to just give you some examples of patients who was treated for, with renal retardations. This is one example that I had a 76-year-old lady. She's diabetic. She has had a bypass in the year 2001. She was actually referred to me for dialysis by the cardiologist in 2009 because the creatinine has gone up to 444, right? So this is a very high creatinine, and usually by convention, most of the patients will require dialysis with creatinine roughly about 400. But of course, it's different from one patient to another patient. So of course, patients are very resistant to dialysis. She's not very keen. So what we do is we actually try to do what our best possible. We optimize, patient really optimize sugar and blood pressure. So we optimize his anemia with erythropoietin sensitizing agent. We started the patient low protein diet, and we actually started on keto supplement. And good, because the patient not very keen to dialysis, quite resistant to dialysis, patient is very compliant to his diet, and you can see that despite having a quite advanced renal failure, a rapid rise because of the diligent restriction of diet, she was able to actually maintain her kidney function, right? Of course, you can see here, not only that she's able to maintain her kidney function, you can also maintain her hemoglobin. You can see here before starting the erythropoietin and of course ketosteroid supplementation, hemoglobin tend to drop to 8.9. She required blood transfusion. Then HP improved, drop again, transfuse, drop again, transfuse, and drop again, transfuse, and subsequent to the improvement in nutritional status and with the supplementation of erythropoietin, she's able to maintain her hemoglobin and do not require further transfusion. Right. So unfortunately, all good things will end one day. As you can see here, he was referred to me in the year 2019. By the 2017, 7 years, at the age of 83, she was very unfortunate. She got her dengue during the dengue outbreak season in 2015. And because of the dengue, her kidney function deteriorated. And since then, she actually required dialysis treatment, right? So although, I mean, the patient finally succumbed to dialysis, but she actually was able to delay the kidney failure and the requirement of dialysis for almost 7 years until the age of 83, right? Okay. So another good example is that Madam T, she's also another diabetic with hypertension. She was seen by me in the year 2008. She actually had chronic kidney disease with a creatinine of 200 over. And over the next 10 years, she diligently, with the assistance of her very caring daughter, I would say caring daughter, because she really take care of her diet. And you can see the progression was very slow. And over 10 years, but again, all good things ends at the end of 10 years, at the age of 73, because of an episode of pneumonia. She actually goes into renal failure and started on dialysis. Another example of Madam C, a 76-year-old lady. She's much better in the sense that she started off with some infection. So we actually dialyzed her, but subsequent to that, she improved and she was actually subjected to renal retardation with low protein diet. And because she has actually undergone dialysis, she was very particular about her diet and she was able to maintain her kidney function until now. I mean, the last follow-up was just before COVID, and I think I lost her to follow up because after COVID, she did not turn up, probably because of the COVID issue. Right. Another example, Mr. L, she also had very high creatinine, but because of the motivation that a very supportive family, daughter and son, she actually able to sort of like control his diet. Of course, you can see here there is some time of lapse of control that is usually during the Chinese New Year. And you can see over the next 10 years, more than 10 years, she's able to maintain away from dialysis. Right. So as for the question number 1, can I regain my lost kidney function? I would say to patient, if this is acute kidney injury, yes. But if this is chronic kidney injury, no. But we can actually retard the progression of kidney failure, provided patients are motivated. And if they are motivated and they actually cooperate, they can actually sometimes retard until unlimited duration of time, as you can see in some of my cases here. Right. Let me just go to my second questions. Did my medication cause my kidney problem? This is a very common questions. Right. So I like again to highlight another patient, a 60-year-old gentleman. He's also a diabetic for 10 years. He's not very sure whether he's hypertensive, but he stopped his medication for 1 year, right? And he came with gross edema. The leg was grossly swollen, and he was wheeled in with a wheelchair, and he was breathless. We did the urine examination. His urine FME showed a protein of 4+ and a creatinine of 800. And he apparently has not been taking medication for 1 year. He defaulted his medication for 1 year. In fact, he took some traditional medications, traditional pills, thinking that that will help him. But, well, as usual, he asked the same question. Did my diabetic and hypertensive medicine cause his kidney failure? That really irritate me because he didn't even take his diabetic and hypertensive for 1 year. But despite that, he still asked that question, right? So this is actually real world where patients will usually don't blame themselves. They will always blame the medications, right? They will find something else to blame. So I always ask patients, what do you think is the cause of kidney disease, right? So what are the cause of kidney disease? This is again a chart courtesy of our renal registry. Again, as I mentioned, our National Renal Registry have very good registry of all our kidney patients, dialysis patients, and you can see here 69.2%, 69.2% of all patients requiring dialysis in the year 2018, starting dialysis in the year 2018, is because of diabetes, right? And another 21.8% of our kidney patients starting dialysis in the year 2018 were because of hypertension. So in total, almost 91% of patients starting on dialysis is because of diabetes and hypertension. There's only about 2.6%, another few percent of cases where we do not know the actual cause. Of course, we can say that it could be because of drugs, but again, these are very small number. And if patients still do not believe this figure, they can actually Google this in the Google. You can actually show them this website where these are all the registries published in the internet. These are all registries which is officially published. So these are not figures plucked from the air. These are all official figures. So officially, diabetic and hypertension, because of their poor control, poor management, these are the causes of renal failure, and not most of the time it's not the drugs, right? So I'm trying to move on to number 3, right? Because time is short. I think I'm running out of time. I think another 10 minutes before 45 minutes is up. So I have kidney problem, and a lot of patients are depressed because they think they will die, right? Because kidney is, of course, a very essential organ in your body. So, but if you look at the WHO website and even WHO publications, kidney failure is not listed as one of the main cause of death in the world. As you can see here, 1990, heart disease is number 1. In 2010, again, heart disease remained number 1. In fact, as you can see here, kidney disease is not listed as a cause of death in the world. Not a major cause. Why is it so? Because in kidney failure, even when the kidney fails, there is what you call renal replacement therapy. Kidney function can be replaced, all right? Replaced in the sense of course, dialysis, and of course, the best treatment would be a renal transplant. So in kidney failure patient, we always tell them, of course, the best option is a kidney transplant, where an extra kidney, a donated kidney will be harvested and implanted in the inguinal region of the patient. Right. This renal transplant is not something new. The first renal transplant, successful renal transplant, were actually between identical twins in the year 1954. Okay, these are pictures of their pictures after the operation, and a lot of people were mistaken that perhaps this is the patient who actually suffers of kidney failure and received the transplant. No, in fact, this is the person who actually received, who is actually the altruistic, means the donor of the kidney. This is the donor. In fact, the donor suffer more than the recipient, because to remove the kidney, you need a relatively major surgery, and to put the kidney, actually is a simple surgery just below the skin. So this is the guy who actually suffered from renal failure and received a kidney from his brother. And this is another example of very successful renal transplant between another twins in 1956, which have 2 important milestones, right? These twins were transplanted in 1956, 2 important milestones. This is the first kidney failure patient who actually transplanted, who successfully delivered a living baby. And the second milestone is that she actually able to live to a ripe age of 76 with a transplant period of 55 years. She was born in 1935. She was transplanted in 1956. Unfortunately, because of age, she died in the year of 2011 at the age of 76. At the moment, this is the longest transplant recorded in the history. Sorry. Let me just grab about 4. Right. So in Malaysia, we always say Malaysia boleh. Yes, in this case, Malaysia also boleh. In 1975, not long after, we also have our first transplant. Sorry, I think I talked too much. Bear with me. So hopefully I get my voice. So our first transplant was in 1975. This is the gentleman who actually transplanted. Again, this is between two brothers. They are not twins, but brother to brothers. It's also very unfortunate for us because subsequent to that, I was told that he actually died not because of kidney failure, he died because of snake bite, right? All right, so this is another example of kidney transplant. And I have the privilege of working in Hospital Kuala Lumpur. The mother actually donated her kidney to her young daughter. All right, so apologies to all the Muslims, but in fact now, not too long, I mean, not just a few weeks ago, there's already a published first case of a genetically modified kidney from a pig to human in US. Of course, it's a successful transplant, but of course, this is still in the very early stage of transplant. Xenotransplant meaning transplant from genetically modified animal kidney to human kidney. And hopefully in the future, there will be more successful story. And of course, hopefully this will actually save more of our patients in the future. Right, this is another, this is actually a chart of one of my patients who actually had a successful transplant. She is a 34-year-old lady. She actually suffered from IgA nephropathy. She actually suffered from end-stage failure in 2014. She came in with creatinine 1,695. I still remember her because she was actually warded in ICU. We have difficulty in convincing her to start dialysis despite being so toxic. But subsequently, she agreed. We started her on dialysis. For 1 year, she was actually on dialysis. And she was lucky to get a transplant. And in 2015, and subsequent to that, as you can see, until I just saw her 2 days ago, she actually living with a transplanted kidney as a normal person. Another good example, in fact, this is even, sorry for the announcement, I think. So this is another more successful transplant that I would like to highlight. This gentleman, 41-year-old Malay gentleman who actually suffered chronic glomerulonephritis, presented early in 2010 with creatinine of over 1,000. He actually started on dialysis and was dialyzed for 3 years. He was dialyzed for 3 years. In fact, he had difficulty in coping with dialysis in the sense that he almost wanted to be medically boarded. So because he can't do dialysis and work, so he think he wanted to be medically boarded. But thanks to one event, there was one case of a brain death, a patient who actually under Datuk, thanks to Datuk Fazli, our neurosurgeon, he had a patient with a brain tumor who actually presented with a brain death. And the family members actually gracefully actually offered the patient's organs to be donated in our hospital. So when the organs are actually offered, our hospital actually have the priority to receive one of the kidney of this patient. And of course, our dialysis patient, JF, he actually was transported to Kuala Lumpur. The kidney was harvested in our hospital, and kidney was sent to Kuala Lumpur as well. Another kidney was sent to Selayang, where 2 patients, and one of the patients is our JF, received the kidney. And subsequent to that, he actually continued working, and I was again seen him last week, and he's doing fine and working well. So this is another successful story of transplant in Malaysia. Right, if transplant is not available, if it's not easily available, then there's of course hemodialysis and continuous ambulatory parietal dialysis. So what is continuous ambulatory parietal dialysis? Wow, this is when I was working in hospital Ipoh. This is my poster boy because he always smile and you can see his shining teeth, right? So this is a gentleman who actually doing CAPD, continuous ambulatory parietal dialysis at home, right? We do home visit, and this is how he's doing it, showing it to us how he's doing it at home. This is another example of a continuous ambulatory parietal dialysis at home. They have their own table, own supplies, their own hook, and they do it themselves. We only monitor them once a while. And of course, we do home visit to make sure that they're doing the right thing. This is another examples of patient doing CAPD at home. In fact, this lady, which I saw her almost 20 years ago, is still doing CAPD strongly in hospital Ipoh. I just saw her, I think last year, when she came over to have some consult. All right, these are another examples of CAPD at home, right? So another thing, 90% of our patients actually elected to do hemodialysis. And hemodialysis is a very long history. And you can see here, in the olden days, in 1950s and 60s, hemodialysis machines are very crude and huge. And of course, now our hemodialysis have become automated. We take blood from the patients and we actually pass through our man-made kidney filter and return back to the patient, right? We do that 4 hours a day, 4 hours in one session, 3 times a week in average, right? Now it's not uncommon actually to see our dialysis patient, many years on dialysis. Like for example, in this newskeeping in 2005, 21 years on dialysis. And our best example of dialysis patient, not in Malaysia, this is a doctor himself. This is the example, Professor Dr. Robin Eddy, a dermatologist. He actually was born in 1940s. In 1960s, when he was a medical student, he diagnosed to have renal failure and he was subjected to hemodialysis. This is his picture then when he was age 20, and he subsequently graduated while he was on dialysis, and he actually had dialysis or renal replacement therapy for 57 years until the age of 70 over. And of course, sometimes for educated patients who like to read inspiring stories, you can actually guide them to this website, this blog site, where the story of Professor Dr. Robin Eddy is actually highlighted, so for this patient actually able to, even though she actually suffered a renal failure at the age of 20, and in the early 1960s, be able to actually maintain a healthy life and become a professor in dermatology, and of course pass on because of old age at 76. Right, these are 2 patients in Ipoh Specialty Hospital. These two patients remind me of how time has fly. Right, okay, this lady already on, by July this year, I'll be working in hospital for the last 50, I'll reach my 15 years of milestone in this hospital. This lady has been on dialysis for almost 14 years. And this gentleman, I always call him young man because he's always younger than me by 1 year. So I always call him young man. He's also on dialysis for, more than 13 years to 14 years already, right? These are 2 examples of patients on, long-term dialysis, and they're doing relatively well. This lady actually over the last 14 years have never been admitted despite suffering from renal failure, diabetes, and hypertension. The only time she was admitted was because of COVID last year during the Delta season, and that also, luckily, she actually able to pass through it successfully without any issue. And of course, I think Dr. Fauzia, our senior nephrologist, would have even more good example to show, because she probably have more patients on dialysis, more than 20 years perhaps in her management. Right. So dialysis is also very important. I'd like to show that dialysis adequacy is very important to maintain a patient's health, right? So there are, in 2011 itself, we have almost 560 dialysis centers in Malaysia. And survival of patients actually varies, right? So some centers can have survival above 60%, and some centers as low as 0%. So how to maintain a proper dialysis for patient? So it's important to actually have what we call dialysis adequacy. So dialysis, yes, it seems a simple procedure, but we need to be adequate. We need to prescribe the treatment for each individual patient. No two patients are similar. Some patients require dialysis for 4.5 hours, some patients 4 hours, some 3.5 hours, some 3 hours, some need a blood pump of more than 300, some only needs up to 200, some need a dialysis flow of 800. So it depends on patient to patient. So it's important to actually have dialysis adequacy where we actually monitor KTOV and we need to achieve a KTOV of 1.2 or at least a urea reduction ratio of 65% to say that we actually have done a proper dialysis for patient so that they can have a proper adequate dialysis and long-term good long-term outcome. So right, it's also important to monitor for complications like hyperphosphatemia. So it's important to achieve adequate dialysis and of course optimal dialysis to achieve this long-term success in dialysis treatment. So for people, for people who have actually visited Ipoh Specialist Hospital, and of course some of the staff who are actually still a bit confused, this is the entry to our dialysis unit in Ipoh Specialist Hospital. If you enter from behind the parking, we have two units. We have the B unit, the B and C unit. We call it the Bunga Raya unit and the Cempaka unit. Why we call it Bunga Raya and Cempaka? Because we call it B and C because it's a hepatitis B and hepatitis C patients unit. And of course, we have the main unit, which is on the left side. All right, you can see there, that's the entry to the hemodialysis unit. And we, of course, in the past, Sister Margaret would like to put a big fish over here, right? This fish have, because of feed by a lot of patients and therefore actually gained quite a weight as well. And this is one of our, I would say, one of our patients' son, who's a very caring son, right? So now we are actually almost at the end of our presentation, almost 45 minutes. So the question that I posted earlier, I hope you're able to answer them now. Patient once started on dialysis, will all patients need to continue lifelong? The answer is no, because if you have acute kidney injury, actually treated the patient early. If it's acute, diagnose it early. You treat the cause of the kidney injury, perhaps like acute gastroenteritis, you treat lobar pneumonia, you treat the cardiomyopathy, then the kidney function can recover and patients do not need long-term dialysis. But unfortunately, if the patient have chronic kidney disease, well, we cannot retard, and once the patient requires long-term dialysis, the patient will need long-term dialysis. The next question: what is the most common cause of most common cause of renal failure? That is diabetes. And how many percent of diabetes of kidney failure patient is because diabetes? More than 65% of our kidney failure patient is because of diabetes. And then, of course, the third question: what is the second most common cause of renal failure in Malaysia? Hypertension. And hypertension and diabetes actually contribute almost 91% of our kidney failure patient requiring dialysis in the year 2018. And finally, how long can a kidney failure patient survive? Yeah, in the best scenario, if the patient receives proper dialysis with adequate dialysis, time is not. Limit is, there's no limit. In fact, as long as the patient is young, and which, of course, if you start the patient at the age of 80, of course, you cannot get 40 years. But if you start a patient at 20 years, sometimes we can, I believe we can actually achieve more than 40 years on dialysis. So if you have patients who ask you, if I have kidney failure, how long do you think I can survive? You can tell them it's actually unlimited depending on how you take care of yourself. Dialysis can replace your kidney function if you do it properly. And in fact, from the records, we have seen patients on dialysis more than 50 years. Right, with that, I'd like to end my presentation. It's already 45 minutes. I think just nice for me to finish at this point of time and invite questions from the participants.
Okay, thank you very much, Dr. Goh. Okay, so far, do you have any questions? Facebook. Do we have any questions from the Facebook?
I hope I've not bored you all.
I think it is a very in-depth explanation. I think you even provide questions in the early of the presentation, and then at the end we discuss back on the answers for the questions that you have given in the beginning. Okay. Doctor, patient with kidney transplant can survive or live a long time. Okay, as explained earlier, it depends on how the patients control their medications and also their lifestyle. Is that right, doctor?
Yes, the best treatment for kidney failure patient is actually a transplanted kidney, right? Because only a kidney can replace a kidney function. So in a patient who actually receive a transplanted kidney, if they take care well of the kidney, usually again even fare better than patient on dialysis, right? So unlimited. In fact, I have also seen a patient last week already on 28 years on transplant. 28 years on transplant.
Okay. We have another question, doctor. Sorry. Hi, doctor. We normally screen renal profile for patients who creatinine and urine FEME are normal, but EGFR is less than 90. What should we advise them?
Okay, so for screening of kidney patient, the best one is urine examination. Of course, as you mentioned, urine, if it's normal, the next step is to actually do a renal function. For me, if the renal function, or we call it EGFR, depends on the age of the patient, right? So if the age of the patient is above 60, well, we expect the EGFR to be just about 60. So if you have a 60-year-old patient, you don't expect the EGFR to be 90, right? So therefore, it's important to actually interpret the EGFR according to age.
Okay. All right.
I think there's a lot of misunderstanding about the CKD grading, right? Okay, I know that most people will grade. I mean, most people know that the CKD is grade to 1, 2, 3, 4, and 5. 5 being on dialysis, and 1 more than 90. So some people may actually ask, if GGFR is more than 90, why is it CKD? Because CKD 1 and 2, meaning that CKD 1 more than 90, 60 to 90 must have kidney damage. Must have kidney damage, right?
All right, doctor. We move on to the next question, doctor. New patient dialysis, use 1.6 dialyzer with 6 times use, cannot use. TCV low around 58, we change 2.0, still same. TCV still low and can use new dialyzer for 5 times. Why?
Oh, sorry. Can you go slowly? I can't get the question.
Right, new patient dialysis use 1.6 dialyzer with after 6 times use, we cannot use it. TCV low around 58. We change 2.0, still same. TCV still low and can use new dialyzer for 5 times. And they ask why.
Well, this question, I think you have to look into the detail about the patient's profile. Just now you mentioned about 56. Is it packed cell volume or is it something? Because without more information, it's very difficult for me to comment. I think the question is more specific to dialysis, means patient on dialysis, but why the dialysis clotted? We need more information. Maybe there is other issues. Perhaps patient have other hematological problem rather than just kidney problem. So we have to actually look at more detail about the patient, because without the information, we are not able to diagnose the problem with clotting.
Okay. All right, doctor. We also had another question, doctor. How much does the transplant cost?
Okay, transplant, of course, there are actually few types of transplant in Malaysia, right? There is what we call as living related transplant, meaning that, as I shown you, a mother who may actually give, a loving mother who actually give a kidney to their children who have suffered from kidney failure. And usually this kind of case, we actually refer them to government hospital, and this type of transplant is actually free, no charges at all, because this is done in hospital, and subsequent to transplant, all the medication is supported by the government. So in that sense, living related renal transplant is actually free. As for cadaveric renal transplant, meaning that people who actually succumb to illness and have brain death and are very willing to actually donate the organs, and people who actually receive this transplant, again, if they're actually done in a government hospital, is again free, right? So not only the operation is free, subsequent to that, all their medication, which may cost up to 3,000 a month, which they need to be taken every day for the rest of their life, is also subsidized by the government. But if the kidney is not available in Malaysia, if the patient decided to go overseas to get transplanted, in the past, more than 20 years ago, to India, and of course 10 years ago going to China, then this patient is subjected to their so-called commercial pricing. And this is not ethical, because you're actually buying and selling kidney. And this is not done in Malaysia, right? As I'm aware, if patient want to fast track their kidney transplant, it can also be done in the private sector, in Gleneagles, as well as in Prince Court Hospital. But the tune of transplant is at the rough age of between 20 to 30,000 for the transplant surgery alone. As for the medication, they may have to buy on their own if they want to fast track and go to a private center. This is the estimated cost of a transplant in Malaysia. That's right.
Okay, for
I hope
private
I answered
sectors,
it.
for private sectors, it will take for about 20 to 30,000 for the transplant procedure only,
Yes, transplant
not
procedure, because
including
you
medication.
need two surgery, because you need to harvest the kidney from the donor, means the person who actually lovingly and giving a kidney, and of course and as for the patient to receive the kidney to be transplanted into kidney. So two individuals need to be operated. Therefore, this is the cost of the treatment for a living related transplant.
Okay.
Private sector, we do not do cadaveric transplant, because when there is a cadaveric transplant, means a person who actually died because of a certain illness, like for example, brain death, tumor, stroke, and their kidney or other organs are still very viable, their organ can be donated, and this is called cadaveric transplant. And usually these are only done in government hospital, because these kidneys and brain, their corneas will be given to the government hospital. For your information, we have a transplant registry, meaning that patient on dialysis, when they're registered in our National Renal Registry, they actually automatically also registered in the transplant registry, meaning that they are actually listed into the transplant. If there is a kidney available for transplant, meaning that if there is a kidney available, they will be called. Like for example, I told you about the patient that was actually got the kidney from Ipoh Specialist Hospital. When there is a donor, two kidneys available, one kidney will go to the local hospital, whereas the other kidney will go to the national list. Means the national list means that the top in the list will call for the transplant. In fact, usually they will call two persons at the same time, because one is a standby. If the first person cannot be transplanted, they have the second person to receive the kidney.
It depends on the compatibility as well, right, doctor?
Yes, compatible as well. For example, the case, Datuk Fazli case, our neurosurgeon, one kidney for Ipoh. So one of our patient from our hospital and one patient from hospital Ipoh actually went to hospital Kuala Lumpur. Luckily for our patient, he actually was compatible and he actually received the kidney. And unfortunately for the patient for hospital Ipoh, he was a standby patient. He actually go home without the kidney.
As we have experienced before, doctor, I brought a patient from Indonesia requiring for kidney treatment. So I think that case is somehow touched my heart, and
Yeah.
yeah, I think it
Well,
really makes me aware about the importance of kidney health for
yes.
everyone. Yeah.
Therefore, it's important to diagnose them early, treat them well. I mean, and of course, as you can see, in fact, patient can be empowered to go for low protein diet as long as they understand the importance of low protein diet.
Okay, doctor. So we move on to the next question, doctor. What are antibiotics and common medicines in general practice to avoid in CKD patients, doctor?
Okay, so this is a very good question, but unfortunately, it will be not simple. There's many antibiotics, and all antibiotics can be adjusted according to the kidney functions, depending on the severity of the kidney disease, right? So some drugs can be used in normal patients. Some drugs have to be adjusted or reduced in certain kidney problem, and in fact, may be avoided when the patient is actually kidney failure. So it actually depends on individual patient and individual antibiotic at different stage of kidney disease. So it will be very difficult for me to tell you an answer for that question. For example, a good example is ceftazidime, Fortum. In a normal person, you can give them 1 gram 3 times a day. In a kidney stage 3, you can give them 1 gram twice a day. In kidney stage 2, you can give them once a day. And in renal failure, you only can give them once a day. So you have to adjust according to the kidney status, and of course, it depends on antibiotic. That's why it's not easy for us to learn all the antibiotics. So we have to actually know the best, some of the antibiotics, so that, and of course, when we do not know, we have to check. So that's why now good thing is we have our gadgets, so we can actually check according to the kidney function of individual patient.
Okay, doctor. Alright. Soalan yang seterusnya, ayah saya HPT, result RP creatinine high. Doktor buat scan, kata ada satu buah pinggang bengkak. Adakah ada risiko kena dialysis, doktor?
Okey, jadi soalan ni agak susah sekali lagi. Dia bergantung berapa serius creatinine, berapa tinggi, dan bengkak sebab apa, ya. Sebab bengkak kalau dia buat scan atau ultrasound, dia tak berapa pasti apakah sebab bengkak. Mungkin pesakit itu perlu mendapatkan CT scan. Dan bengkak itu adakah sebab batu yang menyebabkan buah pinggang tersumbat dan menyebabkan buah pinggang bengkak? Adakah bengkak sebabkan kuman, itu nanah pada buah pinggang, ataupun bengkak sebabkan masalah darah seperti myeloma of the kidney. Jadi bergantung pada apa jenis, apa sebab kepada bengkak. Jadi bengkak bukan satu penyakit. Jadi bagi saya adalah amat sukar untuk saya memberikan satu jawapan. Jadi kalau boleh, doktor yang merawat akan cuba untuk memastikan apa yang menyebabkan buah pinggang itu bengkak. Jadi biasanya kita tak akan beritahu pesakit bengkak saja. Kita beritahu pesakit, oh ni bengkak kerana ada batu, bengkak kerana ada nanah, bengkak kerana ada penyakit macam multiple myeloma, plasma cytosis. Jadi itu yang menyebabkan, dan dengan itu kita akan dapat memberikan rawatan yang khusus. Kalau batu, kita kena pecahkan batu. Kalau nanah, kita kena rawat dengan antibiotik. Dan jika itu adalah multiple myeloma, yang baru-baru ini saya satu pesakit myeloma, kita akan rujuk kepada hematologis yang akan memberikan kemoterapi, dan subsequent to that ataupun selepas itu buah pinggang dia pulih. Jadi bergantung pada sebab bengkak buah pinggang bengkak. Jadi saya tak dapat memberikan jawapannya.
Baik. Jadi kepada yang bertanya tu, mungkin anda boleh refer semula dengan doktor anda untuk further discussion, ataupun untuk jika anda inginkan second opinion, mungkin anda boleh book appointment anda dengan klinik Dr. Goh Kuan Weng, ataupun anda minta referral daripada Dr. GP anda untuk ke nephrologis yang berdekatan dengan anda. Okey. Seterusnya doktor, if patient complain of flank discomfort, dull pain in the morning, is the patient need to check their renal function?
Okey. Biasanya masalah buah pinggang tidak sakit, ya. Jadi biasanya satu tanda masalah buah pinggang bukan sakit. Tapi bila sakit, itu mungkin masalah lain, iaitu masalah tulang ataupun masalah batu buah pinggang ataupun kadang-kadang jangkitan kuman buah pinggang. Chronic kidney disease usually do not have pain, right? So, but of course, if you're worried, it's best to do some examination, because as I mentioned, you're worried of kidney disease, ataupun bimbang tentang masalah buah pinggang, ujian yang paling senang adalah urine examination ataupun urine FEME. Jadi kalau kita buat ujian urine, kalau itu adalah kuman, you akan nampak leukocyte, nitrit dalam urine. Kalau ini adalah batu, mungkin you akan nampak abscess dalam urine. Kalau ini adalah masalah chronic kidney disease, mungkin you akan nampak protein dalam urine. Jadi adalah penting sebab flank pain adalah banyak kemungkinan. Jadi kalau you bimbang tentang masalah buah pinggang, ujian pertama yang anda perlu adalah urine, dan kalau ada masalah kepada urine adalah baik untuk melakukan ujian ultrasound dan juga creatinine.
Okay, baik doktor. Alright, jadi harap saya pada yang bertanya tu faham ya. Okay, so we move on to the next question. We were told in the old days to start referring to FMS when creatinine is around 130 and refer nephro when creatinine is 1780 to 180. What is your comment, doctor?
Okay. This is in the government setting. Dalam setahu saya di hospital kerajaan, di mana workload ataupun tata kerja yang sangat banyak, terutamanya musim COVID. Itulah sebabnya nephrologist dan juga FMS menetapkan satu angka untuk menyenangkan doktor-doktor primary care untuk merujuk pesakit kepada FMS ataupun family medicine specialist ataupun kepada nephrologist. Jadi bagi saya tak ada satu angka yang tepat, tapi sebagai guide seperti yang telah diberitahu, jika creatinine lebih 200, itu adalah satu tahap yang sesuai untuk dirujuk kepada nephrologist untuk mendapat pendapat mengapa creatinine melebihi 200. Kerana ini bila creatinine 200, terutama untuk seseorang yang muda, ini adalah kira serius. Tapi ini adalah secara angka yang secara kita panggil untuk memberikan satu guidance ataupun rujukan, tetapi tidak semestinya diikuti setepatnya. Jika anda rasa masalah buah pinggang adalah serius, adalah baik untuk merujuk kepada FMS ataupun kepada nephrologist untuk mendapat pendapat ataupun pemerhatian lebih lengkap. Sebab seperti yang saya ketengahkan di sini, creatinine adalah satu tahap yang sudah serius. Bila creatinine sudah tidak normal, terutamanya untuk seorang yang berumur muda, jadi ini adalah serius. Tapi yang paling tahap yang awal adalah sebenarnya dalam urine. Bila kita nampak urine protein, creatinine walaupun normal, dan protein ini adalah berterusan ataupun kekal berterusan, bukan satu kali, dua kali, tiga kali, anda perlu mungkin mendapatkan rawatan FMS ataupun nephrologist walaupun creatinine adalah normal. Kerana ini adalah permulaan masalah buah pinggang, dan jika ini dapat rawatan yang setimpal pada peringkat awal, kita boleh mengelakkan daripada acute kidney injury kepada chronic kidney disease.
Okay, baik. Alright, doctor. Kita proceed. We proceed with to the next question, doctor. Is stem cells regenerate kidneys, doctor?
Okay, isu stem cell adalah sangat kontroversi. Sampai hari ini saya rasa kita tak ada satu kita kata rawatan stem cell yang betul-betul menunjukkan keputusan yang positif. Right? Stem cell, kita mesti faham apakah itu stem cell. Stem cell adalah satu sel yang boleh bertukar kepada sel-sel yang lain. Macam mata, jantung, tangan, kaki dan buah pinggang. Jadi stem cell maksudnya adalah sel utama, yang pertama, yang akan boleh bertukar. Jadi kalau kita boleh mengawal stem cell ini, maksudnya manusia akan menjadi hampir Tuhan. Di mana kita boleh menghasilkan mata yang baru, tangan yang baru, kaki yang baru, buah pinggang yang baru. Tapi saya bukan kata tidak boleh, tapi kemungkinan pada satu masa yang akan datang, kita akan berjaya mengawal stem cell dan boleh menghasilkan stem cell yang boleh dikawal dan ditukar kepada sel-sel yang kita perlu. Jadi katakan masalah buah pinggang, kita boleh tukarkan stem cell ini kepada sel buah pinggang. Jadi konsep stem cell ini adalah bagus, tetapi sampai hari ini saya rasa manusia masih tidak dapat mengawal proses stem cell ini. Jadi terutama sekali kalau kita menggunakan stem cell bukan manusia. Kata stem cell daripada kambing, stem cell daripada lembu. Jadi ini stem cell yang akan menghasilkan sel lembu, bukan manusia. Jadi kalau ada orang kata stem cell ini boleh menolong anda, saya rasa you kena tanya dia, bukan tanya saya. Sorry, saya tidak dapat memberikan jawapan yang khusus. Tapi kita harap, sebagai doktor, kita harap satu masa nanti researcher ataupun saintis-saintis kita akan berjaya mengawal, dan jika berjaya, maka mungkin kita boleh menghasilkan buah pinggang, boleh menghasilkan otak. Sebab yang saya rasa yang paling ketara untuk penggunaan stem cell sekarang adalah dalam bahagian otak, di mana saya rasa ada kes yang untuk Parkinson disease yang telah berjaya menggunakan stem cell untuk mengurangkan masalah Parkinson disease. Tetapi belum secara besar-besaran. Alright? Itulah sebabnya kadang-kadang kita tengok ada orang menggalakkan kita menyimpan stem cell anak-anak kita. Maksudnya masa anak bersalin, stem cell iaitu daripada placenta yang daripada untuk anak-anak kita disimpan pada masa akan datang. Bila saintis kita tahu macam mana menggunakan stem cell ini, maka stem cell ini boleh digunakan untuk penyakit tertentu. Bila boleh. Bukan stem cell daripada kambing, bukan stem cell daripada lembu ataupun haiwan, sebab saya rasa stem cell mereka adalah stem cell mereka.
Betul.
Jadi ini penting, sebab adalah penting untuk kita faham apa itu stem cell. Sebab manusia kita keluar daripada stem cell, satu sel. Dan sel ini akan bertukar kepada sel tangan, sel mata, sel kaki, sel buah pinggang, sel jantung. Jadi selepas bertukar, dia tak boleh tukar balik. Tapi kita ada stem cell yang kita harap dapat dikawal. Tetapi buat masa ini seperti yang saya cakap, belum ada dapat dikawal lagi. Jadi saya rasa masih dalam ujian ataupun kajian.
Kemungkinan besar mungkin kita perlukan further study lagi. Sebab saya last time saya ada tengok yang untuk blood clot stem cell mereka ada buat untuk masih dalam study, early phase of study untuk rawat diabetes.
Banyak stem cell yang masih dalam kajian, dan paling penting untuk pemahaman semua ialah stem cell adalah protein. Dan protein ini kalau kata orang itu kata boleh makan stem cell, protein ini akan dicerna ataupun dihadamkan oleh usus kita. Jadi stem cell ini akan rosak. Jadi kalau kata ada orang kata okey, stem cell ini akan membantu anda dengan dimakan. Jadi tak mungkin jadi itu sudah tidak betul, kerana stem cell adalah protein, adalah sel-sel. Kalau kita makan ayam, ayam ini akan dihadamkan. Kalau kita makan stem cell pun akan dihadamkan dan diserap secara sebagai protein, bukan sebagai protein, bukan sebagai stem cell. Jadi kalau stem cell jenis yang dimakan adalah tidak mungkin dapat membantu anda, kerana stem cell adalah sel.
Okay, baik, faham. Terima kasih banyak tu.
Sama-sama.
Untuk GFR rate tu adalah bermaksudnya GFR adalah glomerular filtration rate, is a test used to check how well the kidneys are working. Betul, yes, Doktor?
Ya, betul. Okey, glomerular filtration rate adalah sebenarnya ujian yang paling khusus untuk melihat filtration rate ataupun fungsi buah pinggang. Itu adalah ujian yang paling tepat untuk buah pinggang, glomerular filtration rate. Sebenarnya untuk saintis, mereka menggunakan inulin, satu ejen yang disuntik kepada pesakit, dan bila ejen ini keluarkan di buah pinggang, kita akan dapat mengukur ataupun mengukur filtration rate untuk pesakit itu. Itu yang paling tepat. Tetapi paling tepat tapi susah untuk dilakukan. Susah untuk dilakukan. Jadi biasanya kita akan buat EGFR. EGFR. E itu adalah estimate, bukan Internet Explorer. EGFR itu estimate GFR. Jadi sebenarnya EGFR bukan sama dengan GFR. GFR adalah ukuran fungsi buah pinggang menggunakan ujian tertentu. Kalau kita nak buat GFR, ada yang buat inulin, ada yang buat creatinine clearance test, urea creatinine test untuk dapatkan GFR. Itu yang paling tepat. Tapi ini proses yang membebankan, di mana kita perlu menyimpan kencing untuk 24 jam. Okay. Kencing untuk 24 jam dari pagi sampai keesokan pagi, walaupun mandi ataupun pergi ke tandas, kita perlu simpan. Dengan ujian ini barulah kita akan dapat GFR yang tepat. Tetapi apa yang kita pakai sekarang adalah eGFR, walaupun tak setepat GFR, tapi jauh lebih senang. Kerana eGFR adalah daripada calculation ataupun mathematic calculation daripada creatinine. Dengan ujian creatinine sahaja, kita akan dapat mengukur eGFR melalui formula-formula tertentu, iaitu Cockcroft, MDRD, dan dengan ini memberikan kita eGFR yang juga walaupun tak setepat GFR, memberikan kita anggaran fungsi buah pinggang. Dan dengan adanya eGFR, kita berharap lebih ramai yang akan faham tentang fungsi buah pinggang mereka. Jadi katakan fungsi eGFR 60, eGFR 30. Jadi dengan itu ramai yang akan lebih faham dan lebih prihatin tentang masalah buah pinggang. Kalau hari ini saya punya eGFR 50, 1 bulan lepas tu jadi 40. Adakah ini membimbangkan? Ya, membimbangkan. Jadi ini adalah untuk memberikan kita panggil pemerhatian kepada pesakit supaya mereka lebih faham tentang keadaan status buah pinggang mereka. Tapi eGFR adalah satu cara yang senang dan mudah untuk memberikan kita fungsi buah pinggang walaupun tak setepat GFR. Right? Saya harap penerangan saya dapat difahamkan.
Okay. Alright, Doktor. Unfortunately, kita perlu endkan kita punya sesi untuk hari ini dan saya ingin berterima kasih setinggi-tinggi terima kasih kepada Dr.
Terima kasih. Sorry, suara saya pun sudah nampak garau dah sebab kekurangan air dah.
Okay. Tapi untuk soalan-soalan yang kami tak dapat nak jawab, nanti saya akan save, nanti saya akan jumpa Dr. Go semula dan kita akan menjawablah melalui email dan kami akan hantar email itu kepada anda.